The heart is a relentless engine, beating over 100,000 times a day. Each contraction depends on oxygen delivered by the coronary arteries. When oxygen supply can't meet demand, whether from narrowed vessels, increased workload, or a sudden blockage, ischemia begins. The three main coronary arteries are the left anterior descending, LAD, the circumflex, and the right coronary artery, RCA. Blockages in each cause different ECG patterns. Coronary perfusion happens mainly during diastole. Atherosclerosis begins silently. Tiny injuries to the endothelium, from high LDL, smoking, diabetes, or hypertension, allow cholesterol and white blood cells to collect under the surface. Over years, fatty streaks harden into plaques composed of lipids, foam cells, and fibrous tissue. Endothelial dysfunction leads to a loss of nitric oxide. Stable plaques have thick fibrous caps, while unstable plaques have thin caps prone to rupture. When an unstable plaque ruptures, its contents spill into the bloodstream. The body reacts as if wounded, platelets adhere, fibrin forms a mesh, and a thrombus rapidly expands. Within seconds, blood flow can fall to zero. This is triggered by tissue factor exposure, which activates the coagulation cascade. Sometimes the clot forms and dissolves intermittently, producing pre-infarction angina. With flow cut off, oxygen levels crash. Cardiac myocytes switch to anaerobic metabolism, generating lactic acid. ADP depletion causes sodium and calcium to flood cells, swelling them until membranes rupture. This leak of troponin and CKMB are key diagnostic markers. Early ischemia is reversible if blood flow is restored within 20 minutes. Beyond that, necrosis sets in. The infarct spreads from the inner layer, the endocardium, outward to the epicardium in a wave front. This is why time truly is muscle. Electrical instability triggers arrhythmias, such as ventricular tachycardia and fibrillation. This can lead to transmural infarction, full-wall death, or subendocardial, partial, infarction. ST elevation on an ECG corresponds to transmural injury. In the field, aspirin and oxygen help limit further clotting. In the hospital, patients receive heparin, nitroglycerin, and are rushed to the cath lab. A balloon angioplasty compresses the clot, and a metal stent reopens the vessel, restoring perfusion. The goal is a door-to-balloon time of less than 90 minutes. If PCI isn't available, thrombolytics are used. Reperfusion can cause a temporary burst of oxygen-free radicals, known as reperfusion injury. After reperfusion, inflammation clears dead tissue. Fibroblasts form scar tissue, leaving a firm but non-contractile patch. Nearby cells enlarge to compensate, a process called ventricular remodeling, which can later cause heart failure if excessive. The timeline is inflammatory phase, 0 to 3 days, granulation, 3 to 7 days, and scar formation, weeks. ACE inhibitors and beta blockers help reduce remodeling. Recovery continues long after discharge. Cardiac rehab improves strength and circulation. Controlling cholesterol, blood pressure, diabetes, and quitting smoking all reduce recurrence. Heart attacks are sudden, but prevention is daily science in action.